My name is Brad Siff. I am the founder and president of BioWave Corporation. I'd like to welcome you to our webinar. The topic is on high-frequency percutaneous neurostimulation, also known as PENS, for the treatment of chronic, acute, and postoperative pain. My background is as a biomedical engineer, and I have worked at neurostimulation medical device companies for over 29 years. At the end of the presentation, you can leave your questions down below, and we can answer everything during the Q&A period. So PENS is defined as percutaneous electrical nerve stimulation. BioWavePENS, which is our specific pen system, is comprised of a BioWave Pro high-frequency neurostimulator or a BioWave Home high-frequency neurostimulator and our patented Percutaneous Electrode Array. BioWavePENS is the only FDA-cleared PENS device on the market today. It is a patented deep tissue signal technology. It's not interferential current. It's not TENS. It's not a neuromuscular electrical stimulation device. There's no programming. The signals are optimized for passing through skin into deep tissue. The percutaneous electrode arrays are comfortable. They feel like Velcro to the touch, yet they provide a direct conductive pathway through the skin. This technology treats both nociceptive as well as neuropathic pain, so chronic, acute, or postoperative pain. And the result is 3 times better efficacy and 3 times duration of carryover following a 30-minute treatment. So up to 72 hours of continuous pain relief from a single 30-minute treatment. And this system has built-in active feedback control. So the software actually prevents patients from receiving a burn. So it's a very safe device to use as well. So what's the problem with existing stimulation technologies? Well, it has to do with the fact that skin has high impedance and high capacitance, and that prevents low frequency signals. And we define low frequency as 1 hertz to about 180 hertz in frequency. The electrical properties of skin prevent low frequency signals from passing through. So with a TENS unit, as you increase the intensity of the stimulation, you get kind of a noxious twitching sensation at the surface of the skin, which may act like a distraction to the pain, but those electrical signals from the TENS device cannot pass through the skin and get to where the pain nerves are down below that are conducting the pain signals up to the brain. So that's the fundamental problem with conventional electrical stimulation. So we actually have 2 solutions to this problem. One is BioWave's patented high-frequency signal technology. So the BioWave device is operating at 4,062 hertz and a second signal at 3,940 hertz. And these 2 signals are added together inside the device. So the device then delivers both of these signals together to the first electrode. The signals pass through the electrode into deep tissue, and an active electrical field forms inside the body. So as those high frequencies hit any point of polarization, for example, the plus charge sitting at the membrane of the C fiber, that plus charge multiplies the 2 high frequencies together. And the result is a new spectrum of frequencies that occur in a hemisphere approximately 3.5 inches in diameter. So think of about the size of half of a grapefruit, where this new active electrical field forms. And the frequencies in the new active electrical field are around 8,000 hertz. One's at 4,062, one's at 3,940, one's at 8,002 hertz. And then there's another field at frequency at 122 hertz, which is low frequency, and the harmonics of 122, 244, 366, 488 hertz, but at declining intensities. So the key here and the invention is that the body creates a low frequency electrical field internally right at the surface of the nerve. So This is an alternating current device. So what does that mean? The device alternates the delivery of these two high frequencies. So they're first sent to the first electrode, as you just saw, and now immediately the device delivers them to the second electrode. You get the active electrical field in the hemisphere. Like I said, think of half of a grapefruit beneath the second electrode. Now the device alternates these two high frequencies back and forth so quickly between the two electrodes, the body doesn't realize the signals have left either location. So the net effect is that it's as if you're treating two distinct locations of pain, and the active electrical field forms in a hemisphere beneath the first electrode and in a hemisphere beneath the second electrode. So the electrodes must be placed directly over locations of pain. So it makes for a very simple, intuitive to use system. So what's happening in these hemispheres where that active electrical field forms? So first, the mechanism of action on the C fibers is that the electrical field actually inhibits the sodium-potassium ion exchange across the membrane of the C fiber. So it prevents the plus charge, which is the action potential, from forming on the inside of the C fiber. So the electrical field's actually inhibiting action potential propagation along that C fiber because the plus charge, the pain impulse, is prevented from forming. On the A delta fibers, the effect of the electrical field is that hyposthesia is induced. It forms about 5 minutes into the treatment, much like a chemical anesthetic. And that hyposthesia lasts for approximately 20 to 30 minutes following a 30-minute duration treatment. Kind of wears off linearly over that time period. Additionally, there's increased blood flow through that hemisphere, not from vasodilation, but because components of blood have a charge associated with them. When a charged particle enters an electrical field, it has to be accelerated through that field. So that's why we see increased blood flow through that volume of tissue. Additionally, muscle tissue is held in tension during the treatment. So the treatment feels like a deep, smooth pressure sensation, and it's much more comfortable than other forms of electrical stimulation. So patient compliance using the device is excellent. And then finally, empirically, we see a very long carryover effect following the treatment, up to 72 hours with percutaneous electrodes. And we believe that's because the signal technology is directly affecting the transmission of the pain signal along the C fibers and the A delta fibers. So it allows the body to be more efficient at producing its own endogenous opiates like endorphins, enkephalins, and serotonin. So the second solution to the problem is the electrode. And in this case, we have designed a patented percutaneous electrode array. So there is an array of 1,014 needles within a 2.5-inch diameter patch. The needles are 0.74 millimeters in length. This, what we call this percutaneous electrode array, it bypasses the impedance and capacitance of the skin. It's providing a direct conductive pathway through the skin into deeper tissue. The greatest impedance is at the outer 1/4 to 1/2 millimeter of skin. So this is a wonderful way of making it easier for the high frequency neurostimulation signals to pass into deep tissue. These electrodes are sterile, they're single use. As I said, they're comfortable, they really feel like Velcro to the touch, and it allows for the creation of this 3.5-inch diameter hemisphere treatment area where this active electrical field forms in deep tissue. So it's important to understand the difference between electro-acupuncture and conventional pens, as well as conventional pens and BioWavePENS with our percutaneous electrode arrays. So electro-acupuncture and conventional pens are almost identical. They use 1 to 10 3-inch long needles. There's no imaging used to guide needle placement, and stimulation is limited to the tip of the needle in both cases. The difference is in electroacupuncture, needles are inserted along meridians in the body based on Eastern medicine, whereas with conventional pens, these same needles are inserted near where the pain nerves are that are conducting the pain signals to the brain. That's the significant difference. If you look at clinical literature, the response rate in patients is typically 30 to 40% for both electroacupuncture and conventional pens. Now, if you compare conventional pens to BioWave pens, the difference is we have a totally different needle array. Instead of having up to 10 3-inch long needles, we have two 2.5-inch diameter arrays that each contain 1,014 needles. And even though they're only 3/4 of a millimeter in length, BioWave, the BioWave Percutaneous Electrode Array, actually has 3.3 square centimeters of needle surface area through the skin versus conventional pens. If you had all 10 needles, only 2 square centimeters of needle surface area through the skin. The needles in conventional pens and the percutaneous electrode arrays are placed directly over locations of pain, so where the pain nerves are that are conducting the pain signals. But the big difference is with conventional pens, the stimulation is limited to the tip of the needle, whereas with BioWave, you have a 3.5-inch diameter hemisphere that's enveloping all the nerves that are within that hemisphere. So with conventional pens, if the needle is not exactly in the right location where the nerve is conducting the pain signal, you're not going to stimulate the nerve and you won't get an efficacious effect. But with BioWave, if this is where the pain presents, that's where we place the percutaneous electrode. There's an extremely high probability that we're going to capture that nerve. So the placement doesn't have to be so precise. You just palpate directly over the location of pain, and the electrode is placed over that location. We see about an 85% response rate to the BioWavePENS treatment versus only a 30 to 40% response rate with conventional pens. So the treatment regimen it's a 30-minute duration treatment. In a pain or ortho clinic type of setting, typically the regimen is 6 treatments over a 2 to 3 week period. In a sports setting, treatments typically occur more frequently. An athlete may get 6 treatments over 2 to 3 days to accelerate the reduction in pain and get that person rehabbing and returning to play more quickly. Doctors and patients report a cumulative benefit with multiple treatments. Workers' compensation insurance may pay for an initial 6 treatments. That's both in a pain clinic setting or in a professional sports setting. And subsequent treatments may be pre-authorized. If you look at all of our clinical data, this is a very safe, effective way to treat pain. It's convenient, it's easy to use, there's no programming, it doesn't create any work restrictions. It's a way to accelerate patients returning to work. Obviously, it's non-opioid, so if as a physician or healthcare provider, you're seeking ways to help your patient without narcotics, this is a first course foundation type therapy to do that. And outcomes are excellent. You will see significant improved patient outcomes. 85% of patients respond to this treatment. The typical reduction in VAS pain score is between 50 to 75%. This PENS treatment can provide up to 72 hours of continued pain relief, again, using the percutaneous electrodes. There's a significant improvement in function, increase in range of motion, reduction in stiffness and muscle spasm. Activities of daily living are significantly improved. And we see in all of our clinical studies up to about a 50% reduction in opioid consumption and other pain medication use, which is very significant. We're going to look at 2 specific PENS clinical studies that were conducted. The first one was a randomized, blinded, controlled study for the treatment of chronic pain from grade 3 and grade 4 osteoarthritis in the knee. This was conducted at Rush University Medical Center in Chicago. There were 70 patients that were blinded and randomized into live and sham treatment groups. The inclusion criteria included, as I mentioned, grade 3 or grade 4 osteoarthritis of the knee. The patient had to have had chronic pain for more than 3 months, and the initial visual analog pain score had to be greater than 30 millimeters on a 100 millimeter line, so greater than 3 out of 10 in terms of pain. One sterile percutaneous electrode array was placed over the most painful location on the knee, and that was paired with one non-invasive dispersive electrode pad placed in an opposing position. That dispersive pad is still active, just not nearly as active as the percutaneous electrode. A single treatment was performed, and that treatment duration was for 30 minutes. The results showed that the summed pain intensity difference, the PID score, showed the live treatment was significantly better than the sham treatment, with P at 0.0361. The response to how much better do you feel was significantly better for live versus sham over 48 hours post-treatment. Again, this was just a single treatment, and that was at P 0.0007. The assessment for pain control was that 35% of the live group assessed pain control as well or complete versus only 7% of the sham group. That was P of 0.039. And patient satisfaction at 1 week follow-up, 77% of the live group rated the treatment as good, very good, or excellent, versus only 11% for the sham group, as P equal to 0. Very interestingly, for pain medication use, 54% of the live group reduced their pain medication consumption over a 1 week period. Now, normally patients would be doing treatments once a day or several days a week. This is one treatment over an entire week. This group reduced their pain medication consumption versus the sham group, 0 patients reduced their pain medication consumption. So very huge statistical difference. And then in function scores, WOMAC scores from pre-treatment to 48 hours post-treatment, live was better than sham in all categories for pain, stiffness, and function. And this study was published in a journal called Orthopedics in June of 2007. The second study that we'll talk about was a randomized placebo-controlled study on the treatment of postoperative pain following total knee replacement surgery at the Hospital for Special Surgery in New York City. There are 23 total patients randomized into the experimental group and the control group. The inclusion criteria included patients that underwent total knee replacement surgery. Surgery was performed under an epidural anesthesia, utilizing a standard medial parapatellar approach under tourniquet. The TKRs were cemented posterior stabilized knees. Following completion of surgery, 2 sterile percutaneous electrode arrays, PEAs as we call them, were placed on the medial and lateral aspects of the operated knee around the level of the joint line. The knee was covered with a sterile dressing. The ends of the electrodes were accessible outside of the dressing. There were 8 treatments performed in total, 2 per day, separated typically by about 8 to 12 hours over the 4 days that the patients were in the hospital. Each treatment preceded CPM use by 30 minutes. The treatment duration was also 30 minutes. The results show that there was a significant reduction in VAS pain scores from before to after in the experimental group. P was less than 0.05, and there was no change in pain scores in the control group over the 4 days. There was a significant trend toward reduced opioid use in the experimental group, which only used 10 milligrams of morphine by a PCA, as compared to the control group, which used 18 milligrams of morphine by a PCA. So almost half the amount of morphine was used in the active treatment group versus the control group. This was a podium presentation that was done at the Eastern Orthopedic Association annual meeting in October 2008. And it was a poster presentation at the AA, the American Academy of Orthopedic Surgeons annual meeting in February of 2009. I would also mention that because the treatment was performed prior to CPM use, we found that it was much easier for the patients to be on the CPM machine and get through that entire range of motion than those in the control group who had no specific targeted pain relief for their knee. So there are ways that we can focus the active electrical field by changing the types of electrodes that are paired with each other. So if you pair two percutaneous electrodes together, we call that the B set. B stands for bilateral pain, or two locations of pain. We're using two same size percutaneous electrodes. The impedance through the skin is equal at each electrode where it intersects with the skin. And so this set is used for treating two locations of pain, or it could be for treating the origin of pain and a pain site that's most proximal to the origin. That would be, for example, for radiculopathy. We'll show an example of that. Or if these electrodes are 1 inch apart from one another, the active electrical fields intersect beneath them, and you're really treating one large region of pain. So examples, your classic example would be for bilateral lumbar pain. If the pain presents 3 inches to the left of the spine and 3 inches to the right of the spine, that's exactly where we're going to place those two percutaneous electrodes. If someone has a radiculopathy, in this case, a right side radiculopathy, one electrode is placed at the origin. Let's call this L5, but we're about 1/2 inch to the right of center. So we're capturing where the pain signals are coming off the spine at that location. And then the second electrode is placed in the most proximal location to the origin. So the first location that the patient feels pain, in this case, it typically might be in the buttock. Of course, that electrode has to be on the skin. We couldn't get the model to pose without shorts on. So that's a typical presentation for sciatica or lumbar radiculopathy. One large area of pain, for example, might be if a patient has pain throughout the entire shoulder. One electrode could be placed on the posterior side of the shoulder, one on the anterior side of the shoulder. Generally, we want those electrodes over locations of pain, but this placement will get a very good capture of the entire shoulder joint by placing the electrodes in that fashion. Another might be if a patient had bilateral SI joint pain, we can place these electrodes 1 inch apart, and we're going to capture the entire sacral region, the whole SI joint. It's a wonderful treatment for SI joint pain. Now, but what happens if the patient only has a single location of pain? So to treat a single location of pain, we pair a larger area non-invasive electrode with a single percutaneous electrode. The area is larger, so the density of the electrical field is less under the rectangular electrode, and the impedance is much greater because there's no needles. It's just a hydrogel. So the sensation felt by the patient will be much greater under the percutaneous electrode as compared to the non-invasive electrode. So the non-invasive electrode won't act as a distraction to how high an intensity the patient can get to under the percutaneous electrode, which is directly over the location of pain. In addition, we want to place the non-invasive electrode in the most comfortable place to receive stimulation, because again, we don't want it to be a distraction to what the patient feels under the percutaneous electrode at the pain site. So a bony prominence is always going to be the most comfortable location where we want to place that single electrode. This again is used for treating a single location of pain. So an example, if you were treating a trigger point located in the trapezius, as in this first image, we'd place that percutaneous electrode directly over that location of pain. The bony prominence comfortable location for the rectangular electrode is right along the spine of scapula. In the case of plantar fasciitis, and the pain presents right at that location in the heel and arch area, that percutaneous electrode is directly over that location of pain. The non-invasive rectangular electrode can be placed on the lateral calcaneus, or it could also be placed over the lateral malleolus. Those are both good locations that are comfortable to receive stimulation. Some pro tips during the treatment. It's important we can get deeper penetration of the electrical field if the tissue that's being treated is a little bit taut or a little bit in tension. So if we're treating the lumbar area, we actually prefer the torso to be at 90 degrees to the legs. If a patient has difficulty sitting because of pain, they could be lying on their back with their knees up or on their side with their knees pulled in. That gets you deeper penetration of the electrical field into the lumbar region. If we're treating the cervical area, the neck, we want the head tilted forward so the tissue on the back of the neck is a little bit more taut. If we're treating the shoulders, typically a neutral position is fine with the patient sitting. And if we're treating the knee, typically if the knee can be bent at 90 degrees, we get deeper penetration of the electrical field. If it's post-operatively and the patient doesn't have that range of motion yet, that's okay. But if you can get some angle of bend in the knee, we will get deeper penetration of the electrical field. Additionally, motion during the treatment can change the location and position of the electrical field. So if you're treating a shoulder and someone moves their shoulder a little bit or rotates their arm supination versus pronation, that can actually change the intensity and the slight focus of the electrical field in the shoulder. So if the patient moves a little bit and they say, wow, that's hitting the spot, that's a good thing. So it's a little fine tuning of the treatment. Let's talk about the setup for the procedure. So first of all, the treatment can be performed by just about any healthcare provider, a physician, a nurse, a physician assistant, medical assistant, physical therapist, athletic trainer, chiropractor, acupuncturist. Typically, for billing purposes, a physician should be somewhere in the premises, but the treatment does not have to be done by a physician. So you're going to determine which set of percutaneous electrodes to use. If the patient has 2 locations of pain, it's the B set. If the patient has a single location of pain, it's the E set with one that has 1 percutaneous electrode. So you're going to palpate to find the center of the pain location. You're going to mark that spot with a Sharpie. You're going to take an alcohol prep and clean the skin and disinfect the skin as if you were going to give an injection. Make sure you don't completely wipe away the Sharpie mark because you're going to use that as a landmark now for placing the percutaneous electrode. There's a plastic cup that protects the needles in the percutaneous electrode. You're going to gently peel that off of the electrode. Don't hold the wire coming off the electrode. Hold the edge of the hydrogel, that black perimeter that you see in the image in the middle row, and gently peel the cup off. You don't want to bend or kink the metal array. So just take your time and peel it slowly. It comes off very easily. Then you're going to take the electrode and you're going to center it over the Sharpie mark and place it down. And to insert the percutaneous needle array through the skin, we have to apply about 10 pounds of force using your 2 thumbs, pressing perpendicular to the surface of that electrode on the back. And we're going to apply pressure 3 times. Now, the needles don't hurt. They really don't. They feel like I said, it feels like Velcro to the touch, but you are applying pressure directly over the pain site. So just let your patient know you're going to press in that location. It may be a little uncomfortable because you're pressing over the pain site. You press for a couple of seconds with your thumbs together directly over the center of the needle array to insert the needles. Then you're going to press with your thumbs slightly apart at 12 o'clock and 6 o'clock, still over the needle array, not over the black hydrogel area, but still over the needle array. Press again with about 10 pounds of force, get all those needles inserted through the epidermis. And then the third time is with the thumbs at 3 o'clock and 9 o'clock. You're going to press with 10 pounds of force and insert those needles in those locations through the epidermis. So the idea is we want all the needles inserted through the epidermis. We don't want to leave any hot spots with needles sitting at the surface of the skin. This takes literally about 6 seconds, 7 seconds to do. Now you're going to take the lead wire cable from the device, and the two blue connectors at the end of the lead wire cable can connect to either blue connector at the end of each electrode. There's no plus or minus, there's no black or red leads, and they just click together. Then you're going to turn on the stimulator. The startup screen will read 0.0%, and you're all set to begin the treatment. There's no programming. It's very simple. This literally takes about 3 minutes to do the setup. Now, to start the treatment, the patient always controls their own comfort level. So the patient presses the plus button on the device. That increases the intensity from 0% to 0.5%. And the patient needs to keep pressing the plus button to increase the intensity so that the sensation felt by the patient is strong, typically up to tolerance, but still comfortable. Okay, the body adapts to the electrical field, and as it adapts, the sensation will begin to diminish. As it diminishes, the patient needs to keep pressing the plus button to keep that sensation at a strong but comfortable level. The number is not so important. The intensity number on the screen is not so important. What's important is that the sensation the patient feels is a steady, strong sensation through the entire 30-minute treatment. So typical examples of intensity levels might be in the first 5 to 10 minutes, a patient might be around 15% to 25% intensity. Depends what part of the body you're on. We'll talk about that in a second. By the end of the 30-minute treatment, most patients are somewhere between 25% and 50% intensity. If you were treating those same locations with non-invasive electrodes, the intensity might be at twice the level that you would get to as compared to a percutaneous level. You just don't need to get up nearly as high, and you also can't tolerate nearly as high a level. And it's because the impedance is so low and it's so easy for the signals to get into deep tissue, you just don't need that extra intensity level. So when we look at different parts of the body, for example, knees, ankle, and feet, you can tolerate a much higher level of intensity than other parts of the body. So with percutaneous electrodes, the typical range at the end of the 30-minute treatment, the patient might be at anywhere from 30% to 50% intensity on the screen on the device. That, again, it's approximately half of where they might be with non-invasive electrodes. For the lumbar and thoracic area of the back, as well as the shoulders, most patients can tolerate a medium level of stimulation. So the typical range that patients get to with percutaneous electrodes is between 25% and 40%. For neck, elbow, and wrist, those tend to be more sensitive areas to receive stimulation. The typical intensity range reached might be only 15% to 30% intensity at the end of the 30-minute treatment. Generally speaking, we want a patient to try and get to 15% intensity by the end of the 30-minute treatment, so the electrical field, that hemisphere, is getting deep enough to encompass wherever the pain nerves are that are conducting those pain signals. Every patient's physiology is different. So some patients can tolerate a little higher intensity, some patients tolerate a little less intensity, but these ranges that are presented are just roughly what's typical. Again, the number's not important. What's important is that the patient keeps that sensation they feel at a strong, up to tolerance, but comfortable level throughout the entire 30-minute treatment. At the end of the treatment, when the countdown timer reaches 0 minutes and 0 seconds, the intensity immediately drops to 0%. The maximum intensity reached during the treatment is displayed on the LCD. This is on the BioWave Pro device, and it may be noted in the doctor's notes. You want to gently peel the electrodes off of the skin. You want to take the needle sides of the electrodes and place them together so you don't touch them. There's blood droplets on those needles. They get disposed of, and typically in Sharp's disposal. What's typical is you will see a 1.5-inch diameter pink circle on the skin, as in the image here, with 1,014 dimple marks, and that's what's appearing at the treatment site. Approximately half of your patients will have several tiny drops of blood present, 5, 6, 7 tiny little drops. You can clean this with an alcohol prep, with some sterile gauze. No dressing is necessary. The pink circle typically resolves within about 2 hours. If a patient has very sensitive skin or thinner skin, the pink circle may take up to 48 hours to resolve. That's the longest we've seen, but this is completely normal. From a reimbursement standpoint, workers' compensation will reimburse for initial 6 PENS treatments in most states, whether it's in a pain clinic setting or a professional sports setting. There's very good reimbursement through workers' compensation, and subsequent PENS treatments may also be pre-authorized. Automobile and personal injury are also very good payers in many states, and medical necessity, very important, must be stated in the doctor's notes in order to get reimbursement. So those are some of the key points with respect to reimbursement. So in summary, PENS has proven efficacy, and it's a combination of the advanced high-frequency signal technology that's patented and proprietary to BioWave's devices, combined with the patented Percutaneous Electrode Array technology. And those devices together can provide up to 72 hours of continuous pain relief for treatments. And there's definitely a cumulative effect from multiple treatments over time. And one of the great things about this technology is it's so simple to use. The electrodes go over locations of pain. There's no programming of the device. It's literally a power button and a plus button. And additionally, the treatment is very comfortable. As we said, the electrical field feels like a deep, smooth pressure sensation. The electrodes themselves feel like Velcro to the touch. So patient compliance is excellent. Reimbursement is attractive. There are BioWavePENS training videos and support at our website, biowave.com/support. And you can reach any of our clinical specialists or customer concierge specialists at 1-877-BioWave. That's 1-877-246-9283. So thank you very much. If you have any questions, please go down to the question box toward the bottom of the screen and enter them there. And I look forward to answering any questions that you have. Thank you. So first question is, and I get this a lot, can you reuse the percutaneous electrodes? And the answer is no, because they're sterile. And even if you were going to put them back into the same patient, when you remove the electrode, all the little needles are slightly bent. So if you were to try to reapply it and some of those needles fold over on top of the skin, you risk burning the patient. So you absolutely can't reuse them. They need to go in Sharp's disposal following the treatment. Next question is any dressing necessary post-treatment over the percutaneous electrode insertion point? So it's a good question, and the answer is no. The skin typically, as in that last photo in the presentation, will be pink in color. That's normal. You might see 5, 6, 7, 8 tiny little drops of blood. We typically recommend taking some sterile gauze and just cleaning that. No dressing or bandage is necessary. The insertion points are so tiny that those drops of blood don't come back. So no dressing is necessary post-treatment. How many weeks or months does a treatment regimen usually last? So typically, clinically, we recommend at least a series of 6 treatments. From a reimbursement standpoint, typically most insurance coverage will allow or pre-authorize 6 treatments. And those 6 treatments could be done typically within a month, but usually you try to schedule the patient to come in 2 or 3 times a week based on the patient's availability. So you might do 3 treatments a week for 2 weeks, or 2 treatments per week over 3 weeks. That might be most typical. Sometimes the patient can only make it in once a week. So you could do 6 treatments over 6 weeks, and typically insurance will cover that schedule as well. Certain Blue Cross Blue Shield policies are very positive for PENS. In those cases, you may have to pre-authorize a smaller number of treatments. It may be typically like 4 treatments. And if the patient has a positive response, you can then pre-authorize a larger number of treatments over a longer period of time based on clinical evidence that the patient responded positively. So that's typically, what the typical protocol is when when this is used in a clinic type setting and you're treating patients. How long can percutaneous electrodes be left on the body inserted through the skin? So that's a good question. In our first clinical study that we did on PENS, which was on total knee replacement patients at Hospital for Special Surgery, and the electrodes were inserted on the medial lateral joint line of the knee, and the dressing was put around them. The electrodes were left in for 48 hours. So the patient would get a treatment in the morning. They typically get a treatment in the evening, and then that was repeated the second day. And after the second day, after about 48 hours, the dressing was changed. And when the dressing was changed, the electrodes were removed, new electrodes were put in place, and the new dressing was put around those electrodes. So we have experienced that electrodes could be left in up to 48 hours, particularly in a post-op setting, the patient's not moving very much. But if there's going to be a lot of motion, if the patient's going to move around a lot following the treatment, we would not recommend leaving the electrodes in place. So typically, the normal use of this is it's a 30-minute duration treatment. At the end of the treatment, the electrodes are removed, the 2 needle face sides are put together, and they're disposed of in Sharps disposal. Here's another question. Do patients find they build a tolerance over time and need to keep increasing the intensity? And the answer to that is no. There's only adaptation to the electrical field within that single 30-minute treatment. So the body adapts very quickly over the first 5 to maybe 7, 8 minutes of the treatment. The patient increases the intensity so the sensation is as strong as possible, but still comfortable. As the body adapts to the electrical field, the sensation diminishes. As the sensation diminishes, the patient needs to hit the plus button a couple times to keep that sensation at a strong, steady level throughout the 30-minute treatment. So most of the ramp up is in the first 5 to 10 minutes. After that, 5, 6, 7, 8 minutes later, the patient may realize, I can tolerate a little bit more, and they can hit that plus button one or two times. And that's the typical ramp up over the 30 minutes. It's all about keeping the sensation at a strong, steady level. But if the patient, let's say we're doing a bilateral lumbar treatment, and the patient gets to 38% intensity on the BioWave Pro device, The next time the patient comes in for another treatment, plus or minus, they're going to get right to about 38% intensity. There's no accommodation to the electrical field over time with multiple treatments, unlike conventional electrical stimulation. So the real answer is there's no accommodation, and for a particular location on the body, patients tend to go up to approximately the same intensity, plus or minus a little bit, every time they do a treatment. How does BioWave Go differ from the full-size Pro unit? Okay, so BioWave Go cannot work under very low impedance conditions. So when you have a percutaneous electrode and you insert that needle array through the skin and you have a direct conductive pathway through the skin, the impedance at the interface between the electrode and the skin is very low. And BioWave Go was not designed to work under that kind of low impedance condition. So you cannot use percutaneous electrodes with the BioWave Go device. Only the BioWave Pro device and the BioWave Home device can work under those low impedance conditions. And actually, there's a question of, can you use BioWraps with BioWave Go? And for the same reason, you can't use our BioWraps, which are wearable compression electrode garments, because you use conductive cream with the permanent silver fabric in the BioWrap. You also have a very low impedance condition because you have to apply that conductive cream to the skin. So for the same reason, BioWave Go does not work with silver BioWraps, but BioWave Home and BioWave Pro work with our silver BioWraps. What upkeep costs do patients need to account for? There really aren't any upkeep costs with BioWavePENS because this is a procedure performed typically in an integrated healthcare pain clinic. It's not a procedure that's performed at home with, for example, the BioWave Home device. It could be, but it's unusual. So so there's no real upkeep cost for the patient to answer that question. Here's another question. What's the difference between PENS and PNS? And PNS is peripheral nerve stimulation. Well, BioWave actually is a peripheral nerve stimulation device. However, PNS typically refers to implanted devices. So typically there's a lead that's implanted along the nerve, and the device sits on the body externally over where that lead is implanted. The lead is actually the electrode, if you will. And in some cases, you've got a battery pack that's attached to the outside of the body, or you have the entire stimulator and a battery pack that's attached. So you have to, if you have a lead implanted in the arm, you have to wear this device on your arm 24/7, because it only works if the stimulation is on all the time, or if it's on your back or whatever part of the body where that lead is implanted. With BioWave, because we have such a long carryover effect following the treatment, you do a 30-minute duration treatment with our percutaneous electrodes, and then the electrodes are removed. The patient doesn't have to wear anything all day long, and we get this very long carryover with non-invasive electrodes. We have data that it lasts for typically about 8.2 hours post-treatment. With percutaneous electrodes, it can be typically 24 hours and as long as 72 hours because the percutaneous electrode, think of it as a better delivery mechanism, and it just allows for that much deeper penetration of our electrical field. So that's the difference between BioWavePENS and peripheral nerve stimulation, or PNS as it's referred to. Next question, can this be performed by a nurse practitioner without a doctor present? Typically not. The rules in every state differ. From a reimbursement standpoint, the procedure needs to be billed under the NPI number of a physician. Typically, it's an MD or a DO, but that physician does not need to be in the room with the patient. They just have to be present somewhere in the facility. Let's see. There's another question. Is the treatment discontinued if the patient is below 15% tolerance? No, and the reason is everybody's body is different, everybody's physiology is different, and certain parts of the body you can tolerate more stimulation, other parts of the body you can tolerate less stimulation. And if someone can only get up to 10% or 12% intensity on the display, and that feels strong or up to that patient's tolerance, that's okay. They're still getting a reasonably good treatment. So there's no reason to discontinue the treatment if they can't kind of hit that minimum 15% tolerance level. It's a good question. Another question, what is the CPT code used for the treatment? So the AMA publishes appropriate CPT codes for different procedures, and the AMA recommends the use of CPT code 64999 for that procedure. And so it's a miscellaneous code, but reimbursement is available through that code, very good reimbursement. And we have a reimbursement guide that, can provide guidance in terms of the types of doctor's notes that are required and, proving that this is a medically necessary procedure. Question, does Medicare cover PENS? So Medicare actually does cover PENS, but the reimbursement is not adequate enough to make it economically feasible. So we don't recommend treating Medicare patients just because there's not enough reimbursement to cover the cost of the procedure. I think that covers everything. So thank you very much. I greatly appreciate your time. If you have other questions that you think of after later today, please don't hesitate. You can email those questions directly to me at brad.siff, S-I-F-F, at biowave.com, or you can send them to our support team, support@biowave.com, or you can call us at 1-877-BioWave. And we're here to help you answer any questions, provide support, whatever you need. So again, thank you very much for your time. This webinar will be posted on our website. So if you have colleagues that could not attend, hopefully within a day or so, they'll be able to see the webinar on our website. It also gets posted to our YouTube page as well. Again, thank you very much for your time.